The myth of pernicious anemia, there are plenty, not only in general press, but also in the scientific community. At one point it was, Caucasians or from Northern Europeans, so Celtic, Scandinavians, over the average age of 60. Obviously, looking around the room, that's not true. I'm not even sure we see a major ethnic divide. I think it may well be more that that's who's tested for it. So I think we may have perpetuated our own situation to a point. And I think maybe if we open up our testing, we might find that an awful lot of what we believe is completely untrue. Female predominance has been reported in Northern Europe. It's not in America. So we've got so much contradictory evidence, and that in part, I believe, doesn't help anyone. It doesn't help us as sufferers. It certainly doesn't help a GP if you walk in with your list of symptoms. If you don't fit the standard demographic, why will they test you? And in their defence, it's a fair point. I think treatments have moved on, barely. At one point it was cooked liver believed to increase intrinsic factor levels. We now know for a standard pernicious anemia that wouldn't help because the intrinsic factor would be digested by the autoantibody. So it was actually the B12 in the liver that was thought to help. Now we've got the injections with cobalamins, we've got the sublingual lozenges, you've heard lots about all the different cobalamins that are available. We've still got the standard problem that this still isn't working. The fact that we're having to stand here with such a condition that's been known about for years, why are we still using techniques that don't work? Science has moved on so far, we shouldn't be doing it. Most of your injected doses are excreted rapidly, they help, but unless you get them regularly, what impact is it having on the body? We know it's not toxic, but the body doesn't like anything in excess, and then having nothing, from eating the cream buns and all the rest of it. It doesn't help you to eat a vast amount of anything and then have absolutely nothing. So there's got to be an ideal treatment. There's got to be a better way forward, and we need to be looking. We all know the importance of B12, red blood cell formation, nerve linings. It's a major player in being able to line our nerves and allow the conductivity, which is why we have problems. Maintains normal energy, certainly mental alertness. Heart health, promotes sleep, and we know sleep in itself has so many different factors of why we feel better or don't feel better, and that in itself can have heart complications. Normal immune function, normal metabolism, it really is a systemic disease, disorder, whatever you want to term it. So that's certainly my lifesaver. The little molecule whizzing around is actually your cobalamin. I'm going to talk more about the formation of and the chemistry behind it, just to give you a better idea of where my thoughts are going for my research. I mentioned pernicious anemia as one type of B12 deficiency. You can also have defective intrinsic factor, so not just autoimmunity towards it and the antibodies that will attack it. You can have intrinsic factor there, it just doesn't work as it should. Dietary requirements, which are probably the easiest option to solve. Reduced stomach acid production will actually stop the digestion and the freeing of the B12 down the absorption process. Pancreatic insufficiency, again, that will stop part of the process of the protein absorption. And I'll go through it in a little bit more detail in a minute. Bacterial infection or bacterial overgrowth. Bacteria actually have the ability to absorb the B12 complex. So again, this kind of thing can affect, all the bacteria can overgrow in the intestines to cover the receptors completely. Parasitic infections, similarly. Impaired ileal receptors, which are where the intrinsic factor and the B12 actually go to be absorbed. And that can be things like Crohn's disease, ileal disease, any sort of surgeries, that can all affect absorption that way. Also treatments, so things like nitric oxide, often given to women during pregnancy or at sort of times of pain, if you like. This will actually deactivate the vitamin B12 you've got in your system. So you could be tested for it and your B12 will be absolutely fine, the levels are there, but it's not active. It can't actually do its job. Similar with radiation therapy. So what we need is a fabulous test that will tell us exactly which part is wrong, what is missing, and what type of treatment we can take from it. We don't have a robust laboratory test. Martin was telling us about it earlier. The testing is so broad, it can include peripheral blood smears, enzyme assays, gastric secretion assays, cobalamin assays. Used to be the Schilling's test. They've now stopped doing that because it uses the part of the compounds in it are toxic, so that's now been discontinued. Bone marrow tests, vitamin B12 trials, if you're lucky. So basically, it is a really complex clinical picture, and it's something that, again, because we don't have the standard demographic, it's not at the forefront of anybody's mind to test for this. Again, the haematologist, it's not always in their interest to find out what the underlying cause is. Partly because the tests aren't clear and don't work, they're expensive, but also because the treatment's similar or the same. So because we only have a one-size-fits-all treatment, why bother finding out the underlying cause and spending more money if there isn't a definitive treatment or a way to make it better? So what would the ideal treatment be? To me, and in my mind, I want something that's going to provide me a small amount, but a small usable amount of B12. I want it to be able to mimic the diet. Anything we do to the body, ideally we want to go as close to natural as possible. I'd like it to be taken orally. I don't want the pain of an injection. However simple it sounds, and I know people want more injections quite often, if we don't have to have an injection, but we can get the benefit, that's going to be so much more comfortable. And it's going to be tailored, and I think this is the crux of what I want to see. I want personalised medicine. We want to be able to deliver what is missing in the body. So if it's intrinsic factor, let's deliver intrinsic factor. If it's one of the other proteins, let's deliver the other protein. There are issues with it, and I'll talk about those sort of in a minute, but I don't think there are issues that are insurmountable. So a little bit more detail really about the journey of B12. Now it's basic, so bear with me. You take in B12 bound to animal protein. In the stomach, the B12 is digested from the animal protein where it's freed, and it binds to a protein called R protein. This protects it and stops the B12 being digested in the stomach. As it moves through, you then it gets freed and bound to intrinsic factor. And this takes it through to the lower intestine where it attaches to more protein receptors. So basically at this point we've got 4 proteins that could possibly be at fault. You've got your R protein, you've got the one we all know about, the intrinsic factor, and you've got the tubulin receptor. So these are, and obviously the animal protein, they're your initial things that we should be looking for to find out if they're there and if they exist. What is a protein? I said a lot of this is based on proteins. All proteins are made from amino acids. It's very simple chemistry. Everything is built, there are building blocks, everything is built from these amino acids. They have a positive and a negative charge, and this is pretty much how they stack together. They differ, you can see there the R group, that's how they differ, and that's how they change in their molecule. Because we understand them so well, we can build these in the laboratory. So I can do a list of proteins and amino acids, and I can build them and I can make them in the laboratory. That's sort of the crux of what I want to see of the personalised treatment. If we look at something like intrinsic factor, it's a protein, it's produced by cells in the stomach, and it's 417 of these little amino acids long. It binds to B12, so it can be recognised by the next protein in the sequence, which is tubulin, which is your receptor in the ileum, which transforms it. Logically, why not deliver this intrinsic factor? If we can deliver that, if that's what's missing, we can deliver it. If we've got autoantibodies, they're just going to destroy it straight off. So this is part of where we have to start getting a little bit cleverer. And this is where nanotechnology comes in. Nanotechnology itself is the manipulation of these materials or this matter at a very, very small scale. The term nano is something that is a billionth of a metre. So best way of thinking about it is something like a marble compared to the Earth. The marble being the nano. The molecule that I showed you there, the carbon-carbon bond there, is about 0.1 of a nanometre. You've seen DNA before. The circumference of the DNA is about 2 nanometres, so it's tiny. But they're being produced, and we can make them from all sorts of different materials, and they are currently being used in medicine. They're being used for contrast agents for MRI, so there's gold nanoparticles being used, and because of the density of the metal, it actually gives a nicer contrast and allows the clinician to be able to target areas. We can produce these little sequences and we can wrap them in little nanoparticles to allow our delivery and to help our delivery. So we can make short chains of the peptides, of the active parts of the peptides, to be able to load them with the cobalamin and deliver them to the body. Within nano, we look at sort of around 50 amino acids. We tend not to go much bigger because it makes it very, very difficult because they have a tendency to fold in on themselves and get all bunched up. So I've talked about the tailored interactions. We can target specific cells. We could target ileal receptors. We can find out if they're working. We can probe cells. This is part of the imaging that's being used. They're being used now for cancer treatment. The first tests on nanoparticles were shown to be toxic, which is why they then went down the cancer therapy route, because your ideal situation for a cancer therapy is something that is toxic. So basically they're injected, they block up the blood vessels, shrinks the tumour, and the tumour dies because it has no blood supply. So there are toxicity questions, but they are well overcome now because of all the research that's gone into the cancer treatment. So why nanotechnology? Well, basically we can get personalised medicine. We can look at which protein is missing and we can then put that protein back into the system. We should be able to get round autoimmunity. We can increase specificity, so we can reduce dosages, which means we can reduce cost. We don't need doctors' time. We can take this over-the-counter medicines. Generally, it should mean we can all medicate and we can all choose with very little toxicity or side effect, whether you take 2, 3 or one supplement. So what's the plan? My ideal plan will be to develop a daily oral supplement that's going to contain the B12 and the active part of the molecule. So something like intrinsic factor, we would choose the sequences in that molecule that 1, recognise the receptor in the ileum, that 2, bind the cobalamin, and we would then wrap it in something like chitosan, which is a very, very simple molecule for the body to digest. It also sticks to the mucosal lining of the stomach. In doing that, what it does is it allows a slow release. So even in patients who've had resections of the stomach and are missing a lot of these receptors, we should still be able to directly target what is there and give it a short-term supply for each medicine. So the Holy Grail, all of this will also help to deliver a low-cost and reliable test, because at the moment we're betwixt and between. If we can't diagnose, then we can't treat. To be able to use that information to develop tailored regimes for every individual wouldn't be overly expensive. It would be a battery of tests with 4 set outcomes depending on what those tests show up. And it may also go some way to define why different people require different levels of the vitamin. It may well be that different aspects in that absorption chain result in different clinical symptoms and different presentations. So it was short and sweet, but I hope it's made some sense that there is interest in developing new technologies.
We've got time for some questions, if anybody would like any clarification. Yes?
You
talked about being able to devise something that overcame the autoimmunity.
Yeah.
I mean, would that be some sort of coating on it so that the antibodies in your stomach couldn't get to the intrinsic factor of B12 on your nanoparticle? How would you stop your own body actually gobbling it up and destroying it?
What the body's looking for, when you're looking at something like intrinsic factor, it's 400 and odd amino acids long. Within there will be targets that the amino acid, that the autoantibody recognises. So rather than cover them up, we just wouldn't put them in. So we would put in the portions of the active compound, and we would hope to be able to leave those portions out. So instead of 400 amino acids, we're looking at possibly 20 amino acids. In which case, hopefully, you can go past by stealth, if nothing else, because it won't be looking for anything so small. But as a backup, we would be wrapping it in something that would also protect it to a degree.
Okay, thank you.
Okay. Got a question from the internet. Somebody's asking, Wayne is asking, how long do you think it would take for this to get to market if you did have your way?
Wow, that's $1 million question. It all depends on funding. We're lobbying, well, everybody's lobbying at the moment, but basically funding's been cut in this country for blue sky research, which is what this would be classed as. So things are now having to go through Europe, and the European projects, there are no real calls that we can put this into. There are some nanotechnology calls coming out in the new year. I think we could probably get to a proof of concept within 12 months, but clinical trials, you've got to talk 2 to 3 years, so I don't think we'd see anything like this for a good 5 to 10 years.
Okay. Any other questions for Anna? Again, we are working with Anna and her team and hopefully we will be able to secure some funding so we can go ahead and develop what we're going to go and develop. There we go. Okay, next up, I think it's... Okay, you may have noticed that there's quite a few Dutch people here today, and we have any more, and we're going to have to start translating. This is Petra Visser, who runs the Vitamin B12 and Pernicious Anaemia Society in the Netherlands. We've had our survey. I know Petra has done a survey of her members, and there's incredible similarity between the length of time it takes being diagnosed and the problems with the treatment as well, faced by our friends in the Netherlands, is quite interesting. So I'll hand you over to Petra.
Thank you, Martin. I know it's been a long day already, and like you, I'm a patient, so I know concentrating. I'll try to be brief. When I was diagnosed in 2005, I'd been having symptoms for many years. I visited the doctor numerous times, I've been to specialists, I've had serious neurological problems by the time I was diagnosed. I couldn't walk straight anymore, I couldn't concentrate, I couldn't remember anything, I kept bumping into things, I couldn't find the right words for things. Everyone probably knows the same problems, you know, and finding your remote control in the freezer and, you know, trying to think of the name of the big white box in the kitchen that's cold and things like that. When I was tested in 2005, finally, and my symptoms were very severe, my doctor did test me. He found the low B12, and luckily for me, he immediately put me on 3 injections a week, followed by 2 a week. Then he told me to self-inject, because I was lucky that my doctor knew that everyone needs their own dosage of B12. He has patients that go after the loading dose straight to maintenance dose of every 2 months and are fine. And he also knows that other people have to stay on weekly or more even to get the good results. It took a lot of B12 to get my neurological symptoms reversed. After about 5 months, it started to diminish. So if I would have had the maintenance dose straight after the loading dose, I would have been in trouble. I kept on weekly until 5 months, and then only slowly reduced the frequency. And neurologically I recovered, well, 99%, except for some fog days. After my doctor told me I had a B12 deficiency, I immediately started looking on the internet for information, and I couldn't find much at that time. In Holland there's one website by a man who made this website because his wife was left with permanent neurological damage because of deficiency. And the only other site I found was Martin's site, with the forum, where I became active as well, was a moderator for a short while. But in the meantime, I was also moderator on a small Dutch forum. And the stories were the same everywhere, worldwide. It didn't matter where you lived, the stories were the same. Problems with the diagnosis, problems with the treatment. Nobody knew much about it. It was just very clear that there was a huge lack of awareness and knowledge about B12. Together with a couple of other patients from the forum, we set up a foundation with the main goal of raising the awareness, gathering, spreading information and knowledge to both patients and physicians. And we now have an extensive website with a lot of information, articles, scientific articles, a very large active forum with over 5,000 members. We answer email, we have Facebook, everything the PAS Society as we do as well. And after all those years, we've seen some improvement since we've been doing this. When we started, a lot of doctors would say B12, B12, don't know that. And now in Holland, one of the most heard comments from doctors is, oh, B12, that's a hype. So at least they're aware, and now we have to just get them to go to the middle again and take it seriously. Yes, it's a hype. Earlier this year, we conducted a large survey with over 1,600 respondents to date. We found there are many similarities between the UK and Holland and other countries. Problems that people face are pretty much the same everywhere. I do believe the focus on anemia, pernicious anemia, is even bigger here than it is in Holland. Maybe because the term is used more here than we use it. And pernicious anemia has the anemia in it, which confuses some doctors to think that you do have to have anemia. It often takes many years before B12 deficiency is considered as a possible cause for symptoms. 25% of the patients in Holland have to ask their doctor themselves to be tested. And only 48% was diagnosed by a GP or specialist. The others were referred to alternative medicine or tested themselves at private labs. If people have been to doctors many times, visit a specialist, have been told it's all in their head, or got a diagnosis that later turned out to be B12 deficiency and not the original diagnosis, been taking medication for many years because of this. A third of the patients from our survey had to wait 5 years or longer before being diagnosed. If you consider that, according to medical literature, neurological symptoms can become permanent after 6 months, you can see the problem is huge. Some people that participated in our survey said they've been having symptoms for 20 years. The problem with getting the treatment is also very similar here as it is in Holland. The only exception is that the maintenance dosage in Holland is 2 months instead of 3. But that's pretty much the only difference, if you get the maintenance dosage at all, that is. The most common misconceptions about B12 deficiency and diagnosis. Oh, that was the some data from our survey. That 70% was only tested for serum B12, and the other tests haven't been done so much. I think I lost. Maybe. No. Can I go back?
Okay.
Back. I think I missed one.
The left arm.
Oh, that one. Yeah, there it is. See? The serum B12 test, it's a conclusive test. This is what most physicians believe. And of course, we all know it's not. It's widely used. It's the test. The new test, the active B12 test, has only been done in 5% of people. MMA hardly is ever done because it's deemed too expensive. Homocysteine is sometimes tested with low normal B12 values. But then the interpretation of this value is also a problem. Serum B12 can be false normal. It can be false high, like in kidney disease and liver disease and lack of transcobalamin. Not to mention test failures. Many articles have been written about that. Serum B12 can also be false low. So it might look like you have a deficiency and you don't. By using serum B12 alone, many patients are being missed. Because it can lead to the permanent neurological damage, you should never rely just on B12 alone. You should always test at least MMA when you suspect a deficiency, especially with the neurological problems, as they become permanent. We would advise always to use either serum B12 or active B12 combined with MMA. This would be like optimal in regard of testing. The problem is it's more expensive. And then you get the problem with the insurance companies, and the doctors don't want to test them because they will be told off that you order a test that costs £70. And then there's the problem of how to interpret these tests, because the same applies to all the other tests. You have false high values, you have false low values. But if you consider the cost of years of visiting doctors, doing extensive tests, very expensive ones, years of medication, it will cost much more than just simply testing people for this in a base level, just when symptoms start. Not wait until neurological problems become severe, but test them straight at the beginning. Like, for instance, sometimes the thyroid is tested in a much earlier stage, the TSH. And we would love to see that B12 would be added to the standard basic testing at a GP's office when someone comes in, and not just older people. Because even in my lab, it's B12 on the form, it's under geriatric. That's the only place where you can cross it. It's under geriatric, which says enough. Because there's no golden test, and patients with clear neurological problems should be treated. And then based on improvement, continue with the treatment. As there's no harm in giving someone B12 that maybe does not have an actual deficiency to try it out. But it is much more harmful not to treat someone before anything becomes permanent. The second one is the anemia. It has to be present. This still persists today. We hear this all the time. Yes, I went to my doctor, my B12 is low, but I'm not anemic, so there's nothing wrong with me. Or it's not serious. You can just go to the drugstore, get a tablet, any kind would be good. Or just eat more meat. Because it's probably because you don't eat well, because you're not anemic. I don't know why they still persist. Our survey showed that only 28% of the people who actually knew their blood values have anemia. Only 50% have enlarged red blood cells. It's been known so long that this anemia is like a myth. The oldest article I found, medical article, dates back to 1905, when it was written that a group of patients developed neurological and mental symptoms before anemia developed. And this goes on, 1929, 1930, it's mentioned all the time. In 1960, Smith wrote in his pretty famous article, Megaloblastic Madness, physicians should be aware that combined degeneration of the spinal cord can occur before anemia develops, and that an early diagnosis and treatment is essential. This was 1960. The Dutch Health Council in 2003 said, hematological indicators like hemoglobin are not specific and sensitive enough. There are indications that neurologic and hematologic symptoms are inversely related. And there are many, many more articles. Why it still persists and why doctors don't pick up on this, I have no idea. It's been a mystery. I've asked doctors and they just don't want to hear that, and that the anemia that is often not present. It's much more not present than it is present. Also heard often is, it's rare. We won't test you for B12 because it's rare. You know, nobody has this. Yeah, older people have this, but not younger people, not children. There have been many studies how many people have B12 deficiency, and there was one article in a Dutch medical journal that said that it's even 5 to 10% of the population. It's not rare. It's common. The total B12. Some parts of it are rare. The inherited disorders we heard earlier about are rare. But the total amount of people with a B12 deficiency is not rare at all. And these results are all based on serum B12 of 148 picomole or less. And we know that serum B12 is not conclusive, so it might be even higher than the 5% that we take on average. The other problem is that they are so focused on older people that they forget that children can have a B12 deficiency. And it's so unknown. Doctors don't test children for it unless both parents have it and parents say, you have to test my child. And then the results of the tests of the children are interpreted as if they were adults. And from research it's been shown that their B12 is higher, their MMA and homocysteine should be lower, but they're treated as adults. And then they get the diagnosis, then they don't want to treat them because, well, injections in children, we don't want to do this. No, but keeping them sick is a much better option. The other problem is that most physicians only know one cause, the pernicious anemia. They test the antibodies, and then when the antibodies are negative, then there's nothing wrong with you. You either don't even have a B12 deficiency, regardless of your other values, but you don't have the antibodies, or it's not serious. They don't know that this test can be negative in 30 to 50% of people with pernicious anemia. It doesn't even show up, let alone in all the other causes. There are so many, Dr. Guildford already put up a whole list of other causes. There are so many. There's like twice the amount. There are so many causes. We also found that about 34% of people are tested for causes only, because many physicians believe that a cause cannot be found, so they won't test it. But of those 34%, in half the cases a cause was found, so it does make sense to test it. Also because some causes you can treat maybe and then restore some uptake of B12. And then there are many problems people face with the treatment. Again, I'll just do that. This was the treatment. There are many different guidelines for treatment. They differ from country to country, from physician to physician, from hospital to hospital, and then guidelines are often not followed or only followed half, made up something. Loading doses differ from daily to nothing at all. Maintenance dosage from 2-3 times a week to nothing at all. And after loading dose, maintenance therapy is often insufficient. It's seldomly based on symptoms, often on blood values. We also see too often, very often, treatment is stopped completely because the serum level rises above reference level. Or they say, well, now you've had your loading dose, you can, no, for years you'll be fine because your level's high, it's no problem. Which brings me to